started. Brill. Hopefully everybody can see my screen okay. And yeah, this is week 4 of the scheme today. Sorry, I'm between 2 screens, so I'll be looking in probably quite a weird place as I'm running through this. But yeah, the idea of today is hopefully by the end of the session, you'll feel prepared to make the necessary changes to your appointment book and prepare for the move to total triage. You will have reviewed and updated your phone system if you've got a phone system that allows that, and your website in preparation for the upcoming change. And you'll have also made sure that your accurate setup is ready to prepare you for the move to total triage as well. And as I said, we've got Susie and Rachel on hand to help run through their practice experience as well. And yeah, this week's all about getting ready and helping you to put the building blocks in place for that move to total triage. So we'll talk about EPR setup, appointment book setup, telephony provider, website, and the Accurix infrastructure as well. And I guess first things first is the EPR and the actual infrastructure of your practice. So yeah, despite moving to Accurix Total Triage and a lot of the action taking place in the Accurix inbox, your EPR will remain the kind of heartbeat of your triaging system. So as you know, it stores all of the patient context that helps you to make the right decisions about how you get patients to the right healthcare professional first time. And it can also facilitate and make sure that all of the appointment slots and all of the additional services that you offered are all set up in the right way to help you to move to total triage. So today what we're going to do is run through some of those EPR changes and the key things that need to happen there to support you to operate a total triage model. And that's going to start with how your appointment book is set up. As I think I touched on earlier, we always get so many questions about how the appointment book is set up and how it should be tweaked or tailored to meet a total triage model. So hopefully we'll cover off some of those today, and keep your questions coming in the chat, and we'll make sure that we answer them. So I guess the first thing to say on that is hopefully you did some of your homework from back in week 1, where you were asked to look at the data and the demand that's coming into your practice and have a bit of an idea of what the ideal would look like. And when we're talking about what the ideal appointment book setup would look like, we're both thinking in terms of the nature of the appointment. So is it urgent? Is it routine? Is it planned? What time frame is it in? And then also which healthcare professional is able to offer that appointment and who is best placed to deal with that patient request. So hopefully you've got an idea of the kind of type of requests you've had coming in and what you would like your appointment book to look at. And then hopefully in this session, what we'll cover is how you actually get to that point and how you, what we call clear the decks in preparation for going live with total triage, and make sure that you have set your appointment book up in a way that's going to set you up for success. And yeah, we'll give a couple of examples today, and then I want to spend a lot of time speaking to both Susie and Rachel about the journey that they've been on with that. Brill. So yeah, as I said, a couple of examples to begin with. First of all, this is from a practice who has 9,000 patients. And what I want to do in showing this is to give you an idea of how some practices have tangibly set up their appointment book, and show you from an example of one list size, which is 9,000, then we'll come on to a bit of a smaller practice in a moment. The slides will be getting sent out, so you can have these to refer back to if you want to take any inspiration from this. But just to pull out some of the kind of key details, this practice found that most of their demand comes in on a Monday and Friday. So as you can see on here, they offer more book on the day appointments on a Monday and more on a Friday as well. So they've amended their appointment book to make sure that they're flexing to meet that demand. One thing which is really obvious here as well, which a lot of practices do, is pop pre-bookable slots in early in the morning. So when you open your triage each morning, it can take a little bit of time to make sure that you've gone through the requests, you've decided what to do with that patient, and then you've contacted them. If you have some of these pre-bookable slots just in the morning or first thing after lunch, it just gives you a bit of time to get through those requests and contact the patient if they do need to come in that day, in a little bit of breathing space rather than risking appointments being missed first thing in the morning. This practice uses self-book, so they've added some detail of the embargoes that they have on their appointment slots as well. So that just means that the appointments are fully utilised, they're not going too far into the future, and that they are managing that as best that they can. And then, yeah, the other point that the practice want to highlight is, although this is the appointment book setup that they've planned as their ideal, things can change. So if the appointment slot is not booked, they can change it to an on the day. They can flex depending on if their demand is changing slightly. So it's not set in stone. It's just an ideal that they have and a template that they work from. So that's one practice there. I also wanted to talk about a slightly smaller practice here because, yeah, we've seen practices from every part of the spectrum implementing a total triage model, and even on this call alone, I think we've got about 80 small practices on board here. So yeah, I want to show how that differs for a practice that maybe doesn't have as much GP capacity or clinical capacity. So the first thing to point out here is that, again, they've gone for a really clear slot and embargo key. So they've used a RAG rating, which is very common across practices that move to a total triage model. And yeah, the most important thing when you're setting these slot types is to make sure that everybody in the practice is very confident on what these slot types mean when they become available and who they can book into these slots as well. So here's just a picture of how they've set their slots. Given they've only got 2 GPs in this practice, the GP's day would typically involve a mixture of both triaging the requests that are coming in, but also holding some appointments themselves. So what the GPs in this practice do is they book out 5-minute triage slots, and that's if patients have an action that can be dealt with in a couple of minutes. They'll pop it into the triage slot and they'll come back to it later. So that might be things like bit notes or any letters or test results, anything that they can deal with asynchronously. They have that blocked out in the morning, so they're accounting for all of that activity. A couple of things to note here: these slots are set to not DNA. They're not sent reminders. We wouldn't want the patient getting a reminder of the GP's work list, and it's hidden from patients. So patients, if you are using self-book, can't see those slots or book into them. It's purely for a GP managing their workload and time perspective. So that's their triage request that they have. Alongside that, they've also gone for a bit of a RAG rating here, and they've got, as you can see, on a Monday, a lot of the appointments are either amber or red, so they're anticipating a lot of on the day demand and making sure that they've got the slot types to suit that. They've only got a couple of kind of routine slots available on the morning there, and again, same themes of blocking out that first thing in the morning so they've got time to work through those requests in the inbox. Just to show you how that changes on a Tuesday, Wednesday, you can see there's much more kind of green slots here. This is when they typically do a lot of their routine appointments, when it's typically a little bit quieter in terms of inbound into the practice. So yeah, that's just a couple of examples there of a slightly larger practice and a smaller practice, and how that has to be tweaked depending on the demand, when your demand is coming in, and the capacity that you have available in your practice as well. And just the final bit about the EPR setup before I move and hand over to any questions into Susie and Rachel. The other part of your EPR, which is really important to make sure that everybody's super comfortable with, is the additional services that are available through your EPR. So in particular, if you are a smaller practice and you share resources around the PCN, making sure that everybody's really comfortable on how you book cross-organisationally and how you request, for example, a physio, and everyone's really comfortable on how that process looks. But also from maybe a local services point of view, and referring into pharmacy first if a request comes in and it's best dealt with by a pharmacist. How is that process run through your EPR, and is everybody in the team really comfortable with that? So just to kind of reiterate some of the messages from previous sessions, practices who move to total triage find that about 25 to 40% of their inbound can be dealt with without an appointment. So that's either dealing with it asynchronously or using services like this to get the patient to the right healthcare professional first time. So I think that is enough from me on EPRs. What I'd like to do now is hand over to Susan and Rachel. Please, could you just talk us generally, I guess, through how your appointment book is set up and how you cleared the decks? We get a lot of questions about how on earth am I supposed to clear up a week or two around go live when I'm already so busy. So any wisdom you can share around that would be absolutely amazing. And please keep your questions coming in the chat for Susie and Rachel to answer.
Sure. Yeah, no worries. Hi. So if we just start first of all before we went live, so to clear the decks, we loads and loads of patient comms. We had open days, lots of social media posts just to inform everybody we were making changes. One key thing we did do is we increased locum sessions. So before we went live, we had our capacity was actually better. And we decided to go live at a time when we knew that it was just after the summer holidays, so it's the beginning of October, and it was the time when we had all the GPs in the September to clear all the workload, and actually we did stop any sort of annual leave for 2 weeks so that people were here and we had capacity of staff, not just GPs, but also our admin and reception staff, because we just needed all hands on deck to make sure that admin was cleared, documentation was cleared, and our appointment availability was at its maximum prior to going live. Obviously, we didn't ask people to cancel holidays if they were pre-booked, but we did actually not, authorise any new requests. We also we made sure that we went live on a Wednesday, not the beginning of the week, because obviously on Mondays your busiest day, and you really do set yourself up to fail if you try and go live on your busiest day. And then we also, on our website, we turned off our form a week before, because with all the comms, people were actually getting quite inquisitive as to what the new triage form was like, how to put in their requests, and then our online consultations were going up, which meant that our workflow was kind of changing. So by turning that off, we managed to, people phoning up, we managed to educate patients, and also we managed to keep the work stream coming in one way. And we also set up a waiting list on System 1 for any of those patients we were concerned about or had any, problems with safety netting or safeguarding. That would put them on the waiting list, and then we could actually move them from the waiting list to the templates and the new way of working on the day we went live. So that's the main thing we did: increase your capacity, have more locums, really good comms to patients, and and also we had scripts for our reception team, so they knew what to say. It was a really clear message to all patients prior to going live. With this, from going live, our templates did change quite dramatically. We were trying to tailor make our templates to actually fit all the GP's separate needs, which was, and our slot types were going through the roof. So we have literally stripped it right back to basics. We've just got 2 slot types. We've got a red same-day appointment and a 2-week pre-bookable slot. So the choice that the clinical triaging doctor has is to either have a patient in on that day or for them to be seen within 2 weeks. And again, we do keep our waiting list in the background for any safety netting issues and any of those patients who we feel aren't going to be able to manage the online form. But to be fair, since we've done that, it's really decreased.
The maximum people we have on our waiting list is about 12, and we've got 19,400 patients. So the patients learn. I think that we always got told that on these sessions, and I have to say they do learn.
They do learn.
They learn quite quickly, and it's quite satisfying when the patients start messaging in, asking for their own appointments rather than relying on a waiting list that they were relying on before.
Absolutely, and our rotas, we've always put on just 2 weeks worth of templates, no more than 2 weeks, because otherwise you get this bottleneck effect where you're trying to pre-book 4 weeks in advance, but when you get to 4 weeks in advance, actually those appointments have gone. So we've also done very clear ratios. We looked at the data. The one thing we will say about Accurix data, it is so easy to use, and actually then when you do use that data, you can really rely on it. And every week it's so similar, even during holiday times, the data is actually really reliant, so we could start planning our capacity better for the week ahead. So on a Monday and Tuesday, they're definitely our busiest day. So Mondays, 48% of our appointments can be booked on the day, and 52% can be pre-booked up to 2 weeks in advance. Tuesday, slightly less, it's 44% on the same day, and 56% can be pre-booked in advance. And then a Wednesday to the Friday is consistently our quietest days. Friday actually, ironically, is the quietest day at the practice. So we have 32 same-day appointments, 32% same-day appointments that can be used, and 68% can be pre-booked. And the ratio, even though it's spread differently across the days, is the same. We wanted like a 60-40 split of same day versus pre-bookable. And even though we set our percentages slightly different on a Monday through to a Friday, we still do have that ratio across the week. So 40 can be booked on the same day and 60% can be booked within 2 weeks. So I would say simplicity is absolutely key. Don't make it overcomplicated. And also managing your rotas, just having 2 weeks of rotas on at any one time, it does mean that you can allow for things like sickness or annual leave, because 2 weeks, if somebody does put some annual leave in 4 weeks, usually you'll be changing your rotas around, trying to find cover, but you can add either more pre-bookables or more same days if you need to at that time. And we do look at the data quite frequently. We have really noticed that things like seasonal changes, so in the winter we might need more same day appointments because there's more sort of like acute stuff, flu and what have you, whereas the summer pre-bookable, especially with annual leave, is definitely more appealing and more popular because people want to pre-book and those kind of like seasonal illnesses and viruses aren't around, they're not so apparent. So that's really key. Simplicity is key. And whilst we were creating the templates, we also we put in some admin slots, 18 admin slots per GP, and that's to stop all the hidden work, so that you can put all of the admin onto the GP screen. So actually it helps with equitability across your practice, and doctors are having a fair share of their work, and they're not just being the same doctor who's really easy and approachable, isn't being picked on every time. Actually their work
is things like fit notes,
blood
all the asynchronous stuff,
blood results, absolutely, that sort of thing. Anything else about?
I think that we also use the opportunity to convert all of our slots to be 15 minutes. So we don't have a differentiation between telephone or face-to-face. They are just a 15-minute appointment, and that allows a massive amount of flex in the system to suit the patient, to suit us. And we've had no real backlash with that. So they're all standardised 15-minute slots, no differentiation.
And the way that the doctors know whether they're coming in face-to-face or telephone, the receptionists have learned if it's a telephone call, it starts off with a telephone number, and if it's a face-to-face, it's either marked F2F if it's because a patient hasn't actually used a self-book link and has actually arranged the appointment over the telephone, or if it says Acrix, then we know it's a face-to-face because actually they've used the self-book link to book themselves a face-to-face appointment. So yeah, that's been really good. And I would say as well, comms is huge, just your comms to your patients and the interaction with your patients. So we had open days and we really promoted our website and the NHS app and all those different things. We've also got a tablet, like a tablet in the reception area where patients can come in and actually fill it out an online form, and the reception team are always there to help. And once they've done it once, they're actually happy to go away and do it rather than make the journey into the practice. So that's really good. And I think it's just making sure that the receptionists feel empowered to know what to say. They have a script and they actually are confident in dealing with those, and because it's the same message, they say it frequent number of times, and patients do learn.
I guess the only other thing that just to add is the really great thing about the 2-week appointment book is that it doesn't matter what happens, every day we will have some appointments available as long as that GP is not on leave in 2 weeks' time, because today we added on the appointments for 2 weeks today, and we only added them on at 9:30 this morning. So that means that whatever happens, most doctors have got appointments to offer a patient within 2 weeks. And we did a bit of an audit after 5 months of going live, and basically 99% of our patients are seen within 2 weeks. And we had a 5-week wait before we went live. So we feel pretty happy with that.
And we have triage coordinators who work, admin team who work, just one of them who work alongside the triaging doctor, and every morning and every afternoon they put the number of appointments that are available for them to book, same day appointments, our ACP appointments and our pre-bookable appointments. So the triaging doctor knows exactly how many appointments they've got to play with on that day, to make sure they don't waste any appointments, so that if we have got lots of same days, sometimes somebody who may have to wait or what should wait 2 weeks, they may call them in slightly earlier, which just good use for your appointment time. So yeah, that's also a really important part, to actually have your visuals by your admin team as to what the triaging doctor has to use on that day.
Brill, thank you. That was super detailed and really helpful. We've had a few questions into the chat as you've been just chatting there. One of the questions from Joanne is about what is your patient demographic, and also how many clinicians do you have triaging or having appointments at any one time?
Sure. So we've got nearly 19,500 patients. We're quite a rural practice. We're based in a town, but actually our catchment area is quite large. And we are quite an elderly, I think we're quite an elderly population really. And everybody kind of thinks, oh, you know, the elderly aren't able to use the form. It really isn't the way at all.
They're not the problem.
They're not the problem at all. It's those who are a little bit more resistant to change who are the ones you've got to kind of win over. So yeah, so we are quite a large practice, and we do have a large catchment area with quite a varied demographic. Yeah, and sorry, what was the other question?
The other question was around how many clinicians that you maybe have
yeah.
on at any time.
So I do the triaging as well myself once a week. So basically on a Monday morning we have 2 clinicians, a GP and myself normally, or another or 2 GPs, and then every other session we just have 1 GP. And we've split our sessions into just half days because the doctors were quite concerned at the beginning that triaging would be a bit intense all day. As it happens, most of them prefer, this is their favourite session of the week, but triaging myself and on the busy Monday morning, I would say that doing it for a half day, by the time you get to lunchtime, you're not making the decisions at the same speed, and you slow down. So I think doing it if you're able to have the luxury of half day blocks, it's worth considering, and it means then that GP's also got appointments to offer their patients in the afternoon.
And that's when it's really useful to use the data, because it's so clear to see when your busiest times are. So it's so apparent that Monday we have the most amount of triages in, because what you don't want to do is have too many triaging doctors, because then it takes away your capacity. So we are triaging doctors. We don't actually have a doctor who does on the day emergencies. So we've taken away the duty. And we use our triaging sessions for that. So actually our capacity, we've not lost out by having a triaging doctor and a duty doctor. Our triaging doctor has kind of replaced that service.
Brilliant. Thank you for that. This one's a slightly longer question. It's about acute versus chronic cases. Are you supposed to see chronic patient reviews within this 2-week period you mentioned, or are they dealt with separately?
No. So all of our chronic disease reviews are predominantly done through the treatment room. So they're dealt with separately. So they would go in and see our nurse or healthcare assistants for their initial observations, and then they will be either booked with a diabetic nurse, or all of the coronary CHD and hypertension are basically booked into those admin slots we talked about, and the GP will go in and look at all of the data that's been gathered, do the medication review, do any cough alerts, make contact with the patient if they've got anything they can notice of any concern. So no, they're not included in the treatment room is still booked sort of 12 weeks ahead.
We just use the triage mainly for doctor's
GP
appointments,
yeah,
not for chronic disease management.
Well, thank you so much. I think that's covered your question, but if not, please do throw something else in the chat. Hi, would you be able to share your appointment book setup and reception scripts, please? Is that something that you have?
Yeah,
we
can send it through to send out. Do you mean now, or do you mean?
If you've got it to hand while I'm doing the next section.
I don't know if we've got the script. We've got our template.
We've got a template. I've just got like a screenshot of our templates. I think it's a Monday to Friday template, which we can share our screens with.
I think simple is the key, is what I would emphasize. Really keep it really simple.
So this is
out of interest, how long did it take you? So you said you started off, you know, trying to flex to meet every clinician's needs, and then you stripped it right back. How quickly between going live and making that change?
Well, no, so we were previously trying to cater to everyone's needs, and we just made the decision that the switch to triage was going to be the trigger we needed to simplify our life. And so our admin support was so excited on go live day she could go in and delete the 85 slot types we had for all the different doctors on the different days of the week and the different this, that and the other. So we just used it as a you know, clean up start date. This is all changed from the 2nd of October.
I'm not sure about
can we share?
Because you're sharing, I don't know if I can share.
Oh, do you want me? I can stop sharing there if that's Susie's requesting. Yeah, if I've just allowed you there, so that should let you know.
Fine. There you go. There you go. Can you see that now?
Yes, we can.
The red and green.
So basically that's a Monday to Friday template preview. So you've got the same day, like the very minimum amount on a Monday to a Wednesday to Friday, beg pardon. On a Monday and Tuesday, the reds are a lot more prevalent, because we do have a lot more patients phoning after the weekend who need to be seen slightly sooner. So yeah, absolutely. So our percentage of pre-book calls is definitely larger towards the end of the week, and you can see the morning and afternoon admin slots. You can't see all of them because unfortunately the screenshot wouldn't allow them all in, but the admin slots tend to be 18 over the day, and we did an audit on all our tasks and all our hidden work, and that kind of worked out, and that generally works well. It really does work well, and it's the same sort of things. Basically, the rule of thumb is if it's work that a doctor needs to do on the day, or can be done within an admin slot, it should go on there. If it's an ongoing conversation and you've got, like a conversation and a task with another colleague or an external member of staff, then we would keep that in a task, but everything else comes out of your system one task and gets put on the screen, so actually all that work is sort of not hidden anymore.
I think the important thing, I guess one thing we haven't explained here, and why people might go, that's not very many red appointments, we have 3 ACPs, advanced clinical practitioners, so paramedics and nurses that are prescribers, and they offer all of their appointments are read. So we have about 75 reds from them on a Monday, for example. So and then we divvy out the rest between each GP list, having a few for their own patients that are more GP appropriate.
Yeah, so the ACPs deal with our acute matters on the day, and we've just kept all the templates to 25. No GP or ACP sees more than 25 contacts a day.
Yeah. Yet.
Amazing.
No, it's not interesting.
There are a couple more questions in. What I might do, just so we can try and keep to time, if you don't mind, as I'm running through the next section of the presentation, Susie and Rachel, just jumping in the chat and just answering those that you can. If you still want to answer one live, just leave it in and we'll come back to it at the end, if that's okay.
Yeah, sure.
Thank you. Please do keep the questions coming, everyone. It's really helpful to see what is on your mind. Okay, perfect. Hopefully I am sharing again now. Brill. So yeah, as well as the appointment book set up in your EPR, and sorry, I think I've seen a question about EPR. That's your electronic patient record, so typically it'll be EMIS or System 1. Sorry, I didn't explain that earlier. There's other kind of digital tools that can really be set up to support your triage process, and one of them is your telephony provider. So this looks like quite an overcomplicated diagram, but this is one of the telephony providers that actually enables you to map out the journey that patients will go on as they call in the practice. And we've heard from practices who've done a lot of kind of innovative things around that, such as a bit of an explanation of the benefits. If you want to save time and not wait in this telephone queue, if you click one, we'll send you a link to our online triage tool, and then that means that they're able to leave the telephone queue and go online and complete that form themselves if they're able to do that. But yeah, the telephone, the messaging around that can also just be really helpful for preparing patients for the upcoming change and just making sure that they're aware of what date you're going live and what it'll mean for them as well. And then, yeah, there's also, I think this is quite commonly overlooked, but the physical environment and how you actually operate your triage system is also super important. So I'm thinking about things like headsets. So when you're completing reception flow requests and completing a triage request on behalf of a patient, it's much easier if you don't have to hold the phone. So have you got headsets for all of the receptionists so they can type with both hands and they can also speak to the patient on the phone? If possible, we hear a lot of great feedback about having a triaging hub and having everyone in one room. That can just help to, first of all, make the triaging seem a bit less scary, a bit less daunting, a bit more sociable. You can ask each other questions of what would you do in this situation, and just means, especially between teams, it's been really helpful for kind of breaking down barriers and making everyone feel a lot more approachable. If your practice is not set up that way, that doesn't mean to say that this triaging process won't work for you. And the most important thing here is just that everyone can really easily communicate with each other. So as long as you have that, so maybe, meetings, particularly when you've gone live at the end of each day, just to wrap up what's went well and if anything was a bit of a struggle, or opportunities throughout the day to just pop through into each other's rooms and just ask any questions. I think, yeah, the main thing here is making sure that everybody involved can communicate with each other, and we're taking lessons as they're coming in. Sorry, Rachel and Susie, that was not a long time for you to break to answer the questions. We're back with you.
Okay, Susie can carry on.
I'll keep answering questions, yeah.
Won't be noisy on the typing. Yeah, I'm more than happy to talk through. So we definitely saw the value in creating a dedicated hub, and that's exactly what we did. We were fortunate enough to have a space. It was a pretty dead space in our practice, actually, and we were always thinking, what can we do with it? So this was a golden opportunity. So we have a hub, and we have 4 computers in there, and basically there's 1 or 2 triaging clinicians, and then usually 1 triage coordinator. We initially thought we'd need 2, but actually it's evolved to become quite slick, and they're quite fast that we've gone down to just only ever having 1. So we created a new role from reception team called a triage coordinator, and we voluntold a few of the receptionists we thought would be good at it and put them in to begin with. And again, like the GPs, a lot of them now find it their favourite place to be. It's a really quiet room. There's no phone calls coming into that room. There is a phone line that they can be contacted by internal calls, and they can ring out if needed. But the general principle when we set out was that this room was to be a quiet room with no contact on the phone to patients, if possible, largely because the clinician needs the headspace to think clearly and to make those triaging decisions quite quickly. So we put some soundproofing on the walls to make it a bit more tolerable as well from that point of view. So yeah, I would definitely recommend, if you're able to, have a space, and if it's not an actual room, then create a space within a room that's clearly the area where triage happens. It's been really nice to see the receptionists working closer with the clinicians, and we can do a lot of learning on both directions, so that what we've noticed is the triage coordinators actually become quite upskilled, and they start to recognise the common trends of what actions happen on a certain type of triage, and they sort of have preempted some things for us now. So they will send a lot of flory questionnaires ahead to the patient before they actually even send it to the GP for triaging, because they've learned that we would like to know a bit more about a lump. So actually, let's send a lesion, let's send a skin lesion flory. They've learnt very quickly that what things we need photographs for. So it's very unusual to get a triage where you would have liked to see a photo and you haven't got the opportunity to have one, or you've been told the patient just can't provide it, and that's how it is. So yeah, it definitely is a nice environment to work in, and both sides have appreciated working a bit closer together, I think. So yeah.
Fab. And there is a couple of questions in, as I just have a look. So one question is, how many clinicians do you have working per day? I think you've talked about
the whole practice.
Yeah, I think this is aside from running the triage. It's just like actual clinician hands on the ground.
Yeah, you might be better to answer that, Suze. How many GPs?
So,
we have got a lot of doctors.
Yeah, we have. So we've got 12 GP partners, we've got 2 salary GPs and 2 retainers, and we have currently 3 registrars, but they're not full-time. So basically we've got whole-time equivalents, we've got partners, we've got 9 lists, and each list is around 2,200 patients. So yeah, we might have 12 partners, but actually they cover 9 lists. And our salary GPs, they both work 6 sessions a week. One of them job shares with our partners to look after a patient list, and the retainers do 4 sessions a week.
So it varies from day to day, but
yeah,
obviously got a relatively, feel fortunate. We know we've got quite a good capacity.
Brill. There's another question about, I think you mentioned some of the GPs that maybe wanted their own setup, or maybe works in a certain way. So a couple of questions here. One is, how did you deal, or how would you deal with the GP that wants their own appointment set up when the rest go with the flow?
We just basically told them no. Yeah, we just explained.
We had to get buy-in. We had to get buy-in, and we had a lot of time to basically provide data to we set up right from the beginning our objectives and actually what all the partners wanting from this. And at the end of it, they did realise that actually it was a no-brainer to conform and actually work the same way, because it wouldn't work otherwise. And
I think the key thing is try to at least get them to buy into trialling it the way you'd like it to be done, with the caveat that it's open to discussion. But I think there's a lot of value in trying to standardise your templates. It just creates everything runs a bit smoother. The whole practice understands how everything's working, and it's just easier logistically when running searches, when setting things up. Everything's just easier.
Yeah, absolutely. And we've heard that in the past. That we talked about in the last session as well, about bringing your team on board, like framing it as a trial. It's not permanent. We're all here to learn together. Can be helpful to just get over that initial hurdle and make that leap.
And it's really useful for feedback sessions afterwards. So we had regular weekly feedback sessions, and after we had been live for about 4 weeks, we had a whole practice feedback session. And you do need to take on board what other we may think it works wonderfully set up here, working it all out, but when you're on the ground doing the job, you do need to listen to those people. And actually, we made some really, really important tweaks by involving the whole team. And we sent out questionnaires, didn't we, to make sure that all the team understood and knew how to use Accurix, and that they were all engaged and working from the same song sheet, so to speak.
I think one of the key things that we did change was, if they're triaging in the morning, making sure they had triaging in the afternoon, they had a slightly reduced number of appointments in the morning to give them enough time to clear their admin and have a lunch break. So that is standardized. So we have like a morning triaging GP rota for someone who's triaging in the afternoon, and we have someone who's worked in the morning. So there's slightly less appointments, and that happened through feedback and listening to what people were saying.
Yeah. And there's a question here, and maybe this is my non-clinical mind not piecing them together, but I think it's slightly different to before. You said how many GPs you have and how many clinicians are working. What does that translate to in terms of how many GP sessions there are each week?
74
I think
74. Oh, maybe, around 70. I think 70 sessions.
Brill. And just one more question before I again move us on, but please keep them coming in. Do both partners and salaried GP do triage?
Well, we kind of just wanted partners to do triage, and initially, because actually they could iron out any problems, they could lead by example. We do have a couple of salaried retainers now, as the system is being perfected, that actually we're starting introducing them to do triage. But from the get-go, we absolutely used our partners because they had to be the guinea pigs and they had to invest time to make the system work.
And it just looks good for us as a partnership that we show that we're buying into it and we want to lead from the front and get it right before we expect others to have to run with it. One quick thing, it's really brilliant for registrars to do supernumerary sessions with their trainer, because basically we were losing a lot of appointments with a trainee sat with a trainer. Whereas now, because we're losing that GP's session that morning for triage anyway, we don't lose any slots across the week. That trainee just sits with them and learns how to triage, because all of them are going to have to learn triage, because the way they're going to be working for the next, however many years is going to be through something like this.
And we've utilised the registrar's templates as well, because actually the reception weren't always booking relevant things, might have been chronic cases going to the registrar's templates. But by the GP triaging from the forefront, they can put relevant, especially educational supervisors, relevant matters into that registrar's template on a daily basis. And actually we did notice our appointments, use of our registrars had increased massively.
500 appointments more in the same 3-month period after triage than it was the year before. And they're not complaining, they're happy, because they're seeing the right people.
Yeah, setting them up for when they qualify.
Well, thank you. I'm going to very, very quickly shuffle along because we've got 2 sections left to cover. Again, please do jump in the chat and answer any of the questions if you feel like you can answer them directly in there, Susie and Rachel. Brill. So yeah, we've talked about the kind of infrastructure in your practice, but again, your website and the messaging that you send to patients is also really key to make sure that they're prepared ahead of the change. So the first things to call out on your website is that the messaging on there needs to be really clear and concise, and very clear to patients as soon as they enter that page, how they should get in touch with you, what the routes are and what it means for them as well. So there's a couple of examples on here of just really clear calls to action. So for example, order a repeat prescription that can take patients either directly to the form, or we have what we call quick links now. So that's a relatively new feature of patient triage, and I've just to show you an example of how that looks. What you can do is put a box on your website that says like request test results, and when they click onto that, they're taken to the right section of the form. So they don't need to start at the beginning of the admin and then click onto test results. They can be taken directly to the right form, and it just cuts out a couple of clicks for the patient and makes it really clear what the action is that they want to take. So that's available to you now if it's something that you want to explore as part of this move. And then I just wanted to show you Susie and Rachel's practice here. So Branham Medical Centre is the practice that they work at. And I really liked how clear that this was on their website and what it is that they want the patients to do. So if the patient wants to contact them online, they can click here. Again, they've got sick vit notes, test results, like everything's really clear for the patient in really simple language of how they can access help from their GP. And what they've also done here is produce their own help guides. So if patients are maybe struggling with the form or just need a little bit extra support or a bit nervous, there's lots of self-help guides on here that helps to walk patients through the process. And even to the Contact Us Online link, making it really explicit why the patient should use that form. It can be really, really helpful to just help explain a new process, which can be scary for patients in a way that's really easy to understand. And then, as well as the website, if you do use any social media, that can be a really great way to reach some of your patients. So things like Facebook, Twitter. We've got a couple of examples, but I've just got one on the screen here that just really helps to explain what the new system change means for the patient themselves. And why they should be engaging with this and how it's going to be better. And it just makes the change feel a little bit more digestible and easy to understand. So very quickly, I think you discussed just before we jumped on the call today that your messaging has evolved, and what we've just seen there on your website maybe wasn't how it started. If you could just maybe talk about what journey you went on there and what did resonate best with the patients.
Yeah, so we had to make sure that our website was updated. We used low social media comms, open days, as we said before, and we also had our reception team teaching patients and showing patients pre-go live how our website worked and how the NHS app worked as well, so they could actually use that and they were ready to use it when we went live. And made sure that our website was current and up to date. We did spend quite a lot of time reviewing our website because if you are sending people in that direction, you need to make sure that it's actually all relevant. We used the banner options, so actually we did like a countdown, and our triage go live date was always on the website. And then when we did go live, we just made sure we took the feedback from staff, because actually a lot of problems patients were having where they couldn't find, they weren't looking close enough as to where to click or what box to click for the online form. So we had to make it really simple to say, to make a doctor's appointment, please click here. And the simpler you can be, and the more you listen to the feedback from patients through staff, the more your website will be used and user-friendly, and patients will feel happy using it. We've also got a website on our tablet in our reception screen. It's in the reception area, where patients do come and use it, and reception staff upskill them how to use it in there as well. So it's continual education, and you have to remember that actually some of the patients that you have in your practice, just because your system went live a year ago, it might be, they don't come to the doctors very often. To them, that's still a new system. So you still have to keep the reception team they're forever educating patients, and it's an ongoing educational process. And the more you can educate and the more you can promote and make sure your website's up to date, the better. And just really simple, really clear instructions makes absolutely all the difference.
And two of those tiles that you showed up on our home screen, both Contact Us Online, so Contact Us Online and appointments, they now go to the exact same place, which they didn't when we first went live, because everybody was clicking appointments. We thought it was quite clear, Contact Us Online, but they were all going to appointments. So, we still have, when we look at the data of our website, we still have quite a few hits just on appointments, but it's now exactly the same info. So it doesn't matter who logs in and which one they choose, they'll get the right place. And that was just through listening to what the patients are saying on the phone.
And by looking at your website data, you can see where the patients are going to the most. So if they're going to a certain tile the most, and that's the one you need to make sure is really, really clear and easy to use.
Well, thank you so much for that. And just to jump into the last section and make sure we've got time for any last minute questions. The third and, I think it's actually the fourth and final bit that we want to cover today is how the rest of your Accurix toolbar can support your triaging process. So all of your inbound is going to be coming into this little inbox here. but there's also a whole suite of tools around the toolbar that can help you to deal with that inbound. So I'll talk through each of these in detail, but for those that aren't quite as familiar, we've got the @ symbol here, which is AccuMail, and that's a way for you to communicate with other NHS healthcare professionals about patients' care. You can set up your own templates and questionnaires, and what that can do is just help with your triaging and help make sure you're gathering the information that you need from patients. And then we've also got a whole host of workspace management solutions. So the dashboard, which we've just discussed on there, to help you visualize the demand that's coming in, the kind of admin rights and making sure that people are in the right teams to get the right notifications. That's all available on the little cog there. But let me jump into them in a little bit of detail, and then we'll spend some time at the end asking Susie and Rachel how they've tweaked their toolbar to suit their needs. And yeah, please, if you've actually used any questionnaires or any templates in your practice that you find really helpful, please do share them in the chat. As I said earlier, and encourage you all to join the communities that we have. They're really great places as well for people just sharing questionnaires that they find helpful or templates that they find helpful. So yeah, first things first, templates and questionnaires. So I think in the pack that you were sent at the beginning of the scheme, you should have a link to our questionnaire guide. So this has been created. There are a series of custom questionnaires which you're able to import into your practice, and that can just help you with the triaging process. So yeah, once you get a patient triage request in, the templates and questionnaires are accessible by just clicking on this search bar there. And yeah, to provide a really kind of easy, quick, standardized messaging that both speed up the time for you to send the messages, but also make sure that all the communication that you're sending to patient is really standardized as well. So you're asking things in a really consistent way of your patients. Ahead of moving to total triage, we've heard from practices that it's really helpful to have all this set up front. So you've got everything ready. Obviously that will evolve as you go, and you'll find out what resonates, and seasonally as well, I'm sure different templates will really come into their own. But if you can have a bit of a think about what the standard things you'll be getting in and how you want to respond to them and have them set up before, it can provide a really good base to start with. And we've got some examples as well that we'll share as part of this session. So as well as templates and questionnaires, we've got Self-Book, and I've popped Self-Book, for those who haven't used it, is essentially you can send patients a booking invite. It sends them a link that they can use for 7 days. They can only use it once. You send it attached to a specific slot type, so the patient can only book into that slot type. They don't have free reign over your appointment book. And essentially what it does is just prevents you having to call up the patient, play phone tennis, and try and find a date that mutually works for the patient. They're able to just see that on their phone, do it in their own time, and book straight into that slot. It's an ever-evolving feature at Accurx. So yeah, this on the right-hand side is just some of the changes that we've made already this year. There's a few changes that we're piloting, and there's a few that we're researching. So the more you use it and the more feedback that you give us on it, the more we feed that into our product teams, and that will be getting constantly improved. For example, self-book via email, something that we get asked for a fair bit, and that's currently being researched. And we've made a lot of changes to the telephone appointments, such as making telephone appointments available in batch Self-Book. So please do keep the Self-Book queries coming in. I think Self-Book is probably one of the most used features as part of a total triage process. So if you don't already use that, I would definitely encourage you to check that out. AccuMail. You can build your own directory of services. So I didn't talk you through that on the toolbar, but this little address book, we hear often that practices have the Bible of contacts, which is a physical diary in the practice. You don't need to have that anymore. You can add that all into your AccuMail directory, and then this can become your digital address book. And yeah, it's a really easy way for you to contact other healthcare professionals, and everything, as all of Accurx is anchored around a patient. So what that means is any message you send out, you first have to pull in the patient context, and it just saves any information getting missing or being misconstrued by the person you're sending it to, or linked to the wrong patient. It's all anchored around a patient, and the communication that comes back to you as well, you can save it to record in one click. So it really helps to keep everything in the patient record as the audit trail, rather than it being separated in email and on your toolbar. The inbox, I'm sure a lot of you are familiar with the inbox, but yeah, we're constantly evolving this with feedback that you've given us as well, such as helping you to visualize if somebody else is working through that request at the minute. That's now in there. You can really easily assign requests to certain people or teams in the practice. So for example, if you have a clinical pharmacist that might deal with certain type of requests, really easily just click assign to that team or that person to help you get through that workload. You can add notes that are internal to the practice so they don't get seen by the patient, and that can just help update anyone who goes into that request and let them know what the status is there. And then I think the final thing to say, this is a whistle stop tour through Accurix, but is the settings page in the patient triage under the little cog, and this is where you can control your open hours, what your daily limit might be, whether that limit applies to just admin requests or medical requests. And for those of you who joined us on a webinar a couple of weeks ago where we talked about the upcoming changes in October, you'll notice that we are adding a routine flow under the admin section to help you with the GP contract changes as well. So this is kind of the hub of where you will both control all of your settings and how often the form's available and who to, and also you'll be able to access your dashboards there as well. So use that information to help you continually evolve and improve the model that you are running. And what I will do is just hand over very briefly to Susan and Rachel. How do you use Accurix to kind of facilitate your triage, and what have you found works best?
Yeah, thanks. So we were already using most of the suite of Accurix apart from the total triage, which was one of the drivers why we decided to just go full circle and go for the triage as well. Definitely templates. We wrote a lot of templates prior to go live, and we still use them to this day. Things like detailing, if we're sending a self-book link for a GP, it'll say which days of the week the different job shares work, that sort of thing. We quite often, if a patient isn't contactable, and we want to get a telephone call, we've got a sort of a green routine appointment in the morning and a green routine appointment in the afternoon telephone slot, and we'll book them the appointment and we'll just send them a message saying your GP will ring you between 2 and 5 on this day. So we've got quite a lot of things like that. We use a lot of the flurries I mentioned earlier. Our triage coordinator will send out a lot of the flurries, questionnaires, before it reaches the triaging GP. So if they've got a cough, they'll send that one. UTI is obviously the really commonly one used. Lumps, bumps, or as many as we can get away with using, we try to use them to gather more information. Yeah, the self-book is an absolute no-brainer to me. It's fantastic. We use it across all of our chronic diseases. We've just used it for flu. We use it for face-to-face routine appointments for triage. So anything that's up to 2 weeks, and the patient has a mobile phone, we will just send them the booking link for that particular GP list. And we constantly evolve our templates and adapt them. One good thing I think that I would suggest, we stripped back all of our Accurix templates prior to go live. We went through all of them, tidied them up. It became one person's job to be in charge of monitoring them. So if telephone numbers changed, they all go through that person to go and update them, because everybody's job is nobody's job. So now someone's job is to keep an eye on the templates, make sure they're accurate. If we want to create a new template, they come through that same person, so that we're adding them and categorizing them appropriately with the rest of the ones in existence. So it's all a bit well managed rather than just a bit ad hoc. So yeah, they're the main things probably.
Real. And yeah, there's just a bit of a clarification question here. I think it's off something that I maybe said, where we'd advise that you don't keep the ability for patients to go online and just be able to book into appointments open alongside. What would you say the distinction is there between systems like that allow a patient to just book in versus Accurix self-book, where
well, we want to make sure they're getting the right appointment with the right person in the right time frame. So we obviously only send them a self-book link for the person we think would be appropriate to see them and in the right time frame. If you allow them a bit of a free rein, you can get some selectivity of patients choosing a GP that they may have seen previously, whereas we want them to be seen by their own GP. So I think it's just having that element of control over it, really. It hasn't been a problem for us. As soon as patients realise that the triage system works, once they buy into it and they see that them contacting you means they get what they need, they're quite happy with how it works.
And you can't have booking online and triage doesn't work. You have to keep your appointments free for the triage system. So you have to go for either or.
Brilliant. Perfect. So I think that's us about wrapped up then. We're only 1 minute over, which I think is pretty good on time for this week. So yeah, as a reminder, I think hopefully you've got all the information you need now to take away and have a good look at your appointment book and make sure that you're set up for your go live days. You've got the right mix of appointments and you've cleared the decks in anticipation for that. You've reviewed and updated your phone system and website, and also had a look at any templates, questionnaires. We'll be sending over some examples after, but I think that was some great advice from the team there of yeah, just giving that job to someone in the practice to take care of, and to also evolve the template as your needs evolve as well. It will be something that, as all of these changes, you'll take on learnings and you'll improve the system from there. So yeah, thank you so much everyone for joining, and thank you so much to Susie and Rachel for all of your advice and answering all the questions on there. It's been really brilliant having you.
Thank you.
Thank you.
All right, Brill, have a lovely Wednesday everyone.